see Dilip Fadnis, who is the Director of Syndicated Studies at Alliance Life Sciences. Dilip started his career in the pharma industry at Becton Dickinson and went on to be the CEO of his own research firm called Rowan Group. Dilip has conducted over 65 syndicated studies, so he is a veteran in the industry. And Dr. Joel Auerbach just recently joined Alliance, and he has quite an extensive history as well. He's a 36-year veteran in managed care pharmacy, and he served as Vice President and Chief Pharmacy Officer for Excellis Health Plans, which currently have over 1.8 million members. And he also served as President of HMO Pharmacy Consulting Services, which was a national managed care consulting firm. So with that being said, I am going to pass it over to Dilip Fadnis to give you an overview of some of the developments.
Thank you, Art, and good afternoon, everyone. Good afternoon. As we can see in this slide here, e-prescribing by physicians has grown by leaps and bounds over the last 5 years. In the last year alone, between 2011 and 2012, the growth in e-prescribing physicians was about 25%. Very few things grow at 25% real rate. So it's a pretty strong trend, and it has very strong implications for pharmaceutical marketers, and we'll speak about those as we go forward. So by the end of 2012, approximately 44% of prescriptions, or 788 million, were filled electronically, were sent electronically, and this is a big rise over 2011. And by 2016, 2 billion prescriptions are going to be sent through the e-prescription route. And this is the data from SureScripts company, which is cited at the bottom. And on the pharmacy side, the numbers are equally impressive, if not more. So 93% of community pharmacies are connected for e-prescribing to the SureScript and other networks. And most of the chains are there, and their outlets are shown here, 39,000, and independents at 19,000. So almost all active stores are pretty much signed on to e-prescribing. This is the way e-prescribing works in short. So when the prescriber writes the prescription, it goes to a transaction hub, and from the hub, it sends out an inquiry about the patient information to the PBM. PBM comes back with the eligibility, the formulary information, and the medication history, and the prescription gets filled, the physician gets notified, and the patient receives the prescription. So in simplified manner, this is a schematic of how e-prescribing works. While the schematic was simple and e-prescribing is simple to understand, it has very strong connotations and implications for pharmaceutical marketers. There are two major problems. One is, at the point of prescription, the PBMs are sending messages to the doctors about cheaper alternatives and generic availabilities. And the physicians, just to get things moving and reduce the hassles, are mostly going along with the recommendations. That's the finding from our research. So pharmaceutical marketers are losing a lot of prescriptions to e-prescribing because they're getting switched at the point of prescription. This is a reality. This is a serious problem and has been underappreciated and needs to be paid attention to. On the other side, there are benefits that pharmaceutical marketers can derive from this also. And one is they can send actual drug advertisements to physicians at the point of prescription. And we've seen ads for Lyrica and Xarelto on physician computers when we're doing the research for this study, and for several other products. So this is an opportunity. Also, copay offset coupons can be sent, and they are being sent, and several platforms are routinely attaching them to prescriptions, so the doctor doesn't even have to do anything. it just gets attached automatically for the correct brands. So this is an opportunity to execute a marketing program in this regard. Thirdly, sample vouchers are being sent through e-prescription platforms. And also, because of e-prescriptions, we're seeing increased persistency being observed and being implemented with the prescriptions. So that's certainly helpful. And also, e-prescriptions and e-prescribing platforms help in distribution of patient education. So these are all positive opportunities for pharmaceutical companies. Some leading companies are taking advantage of it. For example, AstraZeneca is taking big advantage of this trend, and a couple other companies, Johnson & Johnson. And others are coming on, they're interested, but just some of them don't know how to do it. Some of them are just testing the waters, some of them are watching and waiting. But in the meantime, some of your colleagues are benefiting from harnessing these opportunities. And behind the scenes, there's a battle going on between drug marketers and PBMs, and you need to get tuned in to see what's going on and what you can do to protect your brands. So very quickly now, the drivers of e-prescribing, just to discuss this trend further. The initial drivers of the financial incentives for MDs to adopt e-prescribing. Then were the sets of penalties for eligible prescribers who did not do it. And then the improvements in EHR that came about. The health insurance companies installing systems into physician practices to spur e-prescribing, which also kind of acted as a driver. And we are now seeing a lot of e-prescribing. 93% of internists are e-prescribing. 84% of PCPs are e-prescribing. So this momentum itself will accelerate future growth, and improved functionality will also fuel further growth in this trend. And now I'm going to turn the presentation over to my colleague, Dr. Joel Orbach. Joel?
Yes, thanks, Dilip. Again, part of the driver for e-prescribing, we can see that sort of having incentives either through MIPA or ERA from a number of years ago was really a profound influence on stimulating the growth of e-prescribing. What's also interesting is that health plans were some of the early drivers of that, often instituting pilot projects in the early 2000s, offering companies or physicians and physician groups equipment at no cost to really get them engaged in the practice. What we're seeing now between the incentives for payment coming from the government, which can be pretty substantial, as well as from the plan perspective, moving from it would be nice to have you e-prescribe to actually a requirement for physicians and physicians groups to participate in health plan quality improvement programs, healthcare reform, medical homes, and ACOs. This is really a substantial driver to this. Just to give you a handle from the incentive standpoint, we're really talking about e-prescribing being one of the meaningful use criteria which in order to qualify for incentive payment, more than 40% of permissible scripts need to be transmitted electronically, and you see that nationally we're above that number. Just to give you a flavor, in 2011, over 282,000 eligible professionals participated in the ERX incentive program, and the government paid out over $285 million to them. Let's move to the next slide at number 10. You can see part of the promise for e-prescribing really falls into 4 areas: patient safety, prescribing efficiency, improvement in quality, and cost savings. There's no question that the old handwritten script is fraught with error. In fact, studies found over 80 eligibility errors per 100 scripts. To reduce that is going to help reduce adverse drug events. It's estimated that 1.5 million preventable adverse drug reactions are attributable to to this each year. When you talk about efficiency, I think this is important. When physician offices look to see how much time are they spending on the time with pharmacies with regards to the illegibility issues, what they find is e-prescribing has less callbacks, obviously better documentation. We're talking about hours per day here in an office, which translates to dollars. Quality is an important aspect of this, and certainly the promise of incorporating medical evidence into the prescribing process, promoting appropriate drug selection, et cetera, was critical. And as Dilip mentioned, also having ready availability to more detailed drug information and dosing, and of course patient education materials was there as well. Detecting non-adherence to medication by the availability of having the medication history at the point of decision making is also critical. What also e-prescribing has demonstrated is that 30% of the written scripts that were taken to the pharmacy never actually get filled. And of course, there's the cost savings alluded to generic drug use or lower cost formulary brand use, certainly a health plan perspective, but also reduction of costs elsewhere in the system. We're seeing reduction in hospital admits due to adverse drug events. You're seeing overall a half-point drop in medical and hospital costs in those pilots looking at e-prescribing. So overall, a lot of promise, and we're beginning to see some of the documentation for that promise becoming a reality. Next slide. We're seeing the platforms for e-prescribing really what driving the opportunities and some of the challenges. These platforms may be subsidized, are free, others charge a fee, and as Philip mentioned, some of the free platforms, there are the subsidies and also have the availability for providing drug advertisements. The platforms can either be electronic health record based, and you see the players in that space, or standalone e-prescribing systems. We believe because overall incentives and meaningful use is a broader need for electronic health records, that pretty much e-prescribing is going to be tagged along with an EHR. And some of the challenges there is that even though we do have some standards with electronic prescribing, the challenge is going to be each system may present maybe different user-friendly capabilities to the provider, and so that may be one of the challenges that we need to get through. Next slide. And typically, and Dilip mentioned this, as with any healthcare topic, there's obviously a variety of different camps on different sides, and in this case, various legislation that's pending that could regulate e-prescribing and the third-party messages. You see the number of states where this is pending. I'm not sure where this will end up. As we all know, there's often very little movement in the legislatures, and there could be an argument that blocking messages that may lead to lower costs for members in terms of out-of-pocket costs may be viewed as anti-consumer, and the question is going to be, does anybody politically want to be on the side of anti-consumer legislation? So we'll have to wait and see what happens here. Certainly this will have some significant impact, as Dilip mentioned. And let me turn this back now over to Dilip to begin to take us through some of the specifics of the work being done.
Okay, thank you, Joel. So now I'm going to present some of the findings from our research, and we have two levels of findings, qualitative and quantitative. So in the qualitative arena, we did some focus groups and depth interviews, and here are the findings from that. We've heard from physicians, we've seen them do e-prescribing, they become very comfortable with this activity. So that's the finding. And they also like to use these copay offset cards through the prescribing platforms because they feel it helps patients and it gives them a prescribing breadth that they did not have before. Also, they're willing to receive advertisements to defray the cost of the system. This has been clearly said to us in the focus group. And they're interested in sample vouchers through the platforms, interested in e-detailing, and also interested in on-demand information services, and they have some other interests which we'll see in subsequent slides. Many questions are there. Some of them you're going to be seeing answered in the subsequent slides, and some are going to be answered later. But thing is, how will e-prescribing evolve over the next few years? I mean, we already reached a point where 93% of internists are e-prescribing, so there is not much growth left there. But some of the large practices of practices over 25 physicians have not gone to e-prescribing. So when they start growing because of ACO or what have you, that number will start increasing again. And which new services will become popular? We have some insights into that too, and we'll be happy to share those. There's going to be a consolidation of the EHR platforms. People like McKesson and a couple of the companies have taken steps to increase interoperability within EHR, and this is going to certainly help e-prescribing. Also, e-detailing is a nice opportunity to go through the EPR platforms, and will it grow in the future? We have some answers in that area also. And we've heard some remarks to the effect that CMS is looking to mandate the use of one certain platform for all e-prescribing, and how that plays out remains to be seen. This is kind of a quick overview of our research methodology for this study. The study is all done now, and we did some focus groups, some depth interviews with physicians, and actually watched them do the e-prescribing to pick up some cues about that. Then did quant phase online questionnaires with primary care physicians, cardiologists, and neurologists. And then after the quant phase, once the tables were analyzed, we questioned them some more, and also did some more interviews with legislators, PBMs, payers, and consultants in e-prescribing. So we have a lot of good information from all these sources. So some of the information can be seen here. So as we can see, the doctor is saying here that e-prescribing has had a positive impact on persistency. Around a third of the physicians, irrespective of the specialty, say that, yeah, in my practice, I've seen a positive impact from e-prescribing on persistency because the prescriptions are not lost in transit. Also, a majority of physicians claim that they decide in advance which brand they're going to prescribe. And we can see on the right-hand side that just the percent of time they decide the brand in advance is like 85, 86%. However, when they really go into the system, things change. And they do change their decision based on the information they got from the PBM. So if they're considering your brand, that could be switched on you. And this is very important to understand. So as you can see in this graph, 46% of all physicians say that they do change their decision, and 16% of them change and switch the drug once they've made up their mind. They switch the drug beyond that. So there's a lot of switching going on. Here we see that there is a lot of physicians who have exposure to pharmaceutical ads and the ability to see detail and contact drug rep. So that can be seen pretty clearly in the broken down by the specialties, all physicians, PCPs, cards, and neuros. In terms of usefulness of services, there are services now which facilitate prior authorization through the e-prescribing platform, and that is becoming a very popular service. That was initially launched by CVS Caremark as the EPA service and getting very popular. And then we see in the graph some of the other services that are quite popular, namely sample vouchers, adding drug to the favorite lists, subsidizing costs for initial or upgrades of the system, providing copay coupons, and ability to order samples. These are all popular services and considered valuable by physicians from the e-prescribing platform. While these services are quite popular, not everyone gets them. So only a small percentage, like less than 20% of the physicians are being offered copay coupons through their platforms. This is because not all platforms offer them, and drug companies have the ability to expand the number of platforms that offer these copay coupons, and then these numbers will increase. Sample vouchers also, the access to this feature is low because not every platform offers it, but physicians think it is very valuable, as you can see on the right-hand side chart, and definitely a service worth considering for pharmaceutical marketers. Same thing with ordering samples. Not all platforms offer it. Allscript does, but opportunity exists for pharma to offer, to get more companies and more platforms to offer the service, because it's considered a very valuable service, as can be seen on the right-hand side. So, instead of generalities, here are specific brands. So, as you can see on the right-hand side, all these brands offer copay coupons through the e-prescribing EHR platform. And some of these are pretty well-known names: Nexium, Crestor, Cymbalta, Xarelto, Symbicort, Nupro, Lyrica, Januvia, Lipitor, Victoza, well-known names. So these brands are offering copay coupons through these platforms. And also patient education material, as can be seen on the left-hand side. And as we go through the years, as physicians become more comfortable with e-prescribing, as drug marketers become more comfortable with this trend, we'll see these numbers grow. Currently, let's say it's 8% for Benicar. We're going to see brands with much higher percentages as the years go on. Same thing with drug ads. We are seeing drug advertisements, and some of the ads we spotted were for Pradaxa, Crestor, Xarelto, Onglyza, Lipitor, Cymbalta. So these are well-known brands, adware, brands from very reputable companies. So we're seeing a lot of drug adverts, and as years go by, as people become comfortable, these numbers are going to grow from 7% to 10% to 20%. Those who are into this early on will derive the benefit of exclusivity and less competition on the space, and later entrants will have to put up with more competition in this area. So these are some of the findings. We have a lot more of these in our report, and just to sum up some things in terms of knowledge about the uses of the study, in terms of knowledge, it will help you understand. The study will help you understand the intricacies of e-prescribing effect and how it's affecting the physician. Learn about the competitive initiatives in this area. What is your competition doing to benefit from this trend? Learn about the information being sent by PBMs, and it has a lot of negative impact on your brands. So good to know what's going on there. Gain understanding of the future evolution of this trend, and learn about services provided to physicians by pharma companies. You'll get the details of what services are provided, which are considered valuable by physicians, and which need to be emphasized and used for the benefit of your brand. On the application side, this report will help you develop an appropriate information package for MDs in content and in format, to develop counter strategies to minimize and neutralize the impact of PBM information, and prepare marketing plans to leverage this trend effectively and minimize the negative impact on your products. We have a comprehensive brochure on this study. If you would like to receive it, you can let me know by sending an email or calling, and I'll be happy to send it to you. And we also are offering a transcript of the focus group with physicians. So if you'd like to receive that, you can send me an email, and I'll provide you the link to the audio and video of the focus group discussion. And I'll turn it over to Art now.
We're going to open it up for Q&A session. I am going to unmute everybody. So if you don't have a question, I would appreciate if you could just mute your line. I'm going to do that right now. And if anybody has any questions, feel free to chime in. Okay, actually it looks like we received a few questions via the chat. So I'm going to, I'll just read those out, and we will field the questions. Okay, so the first question that we have here, so these incentives and penalties that we were discussing are 1 or 2% of what specifically?
Yes, that is something Joel can address better. So Joel, can you take it, please?
Yeah, the 1 and 2%, it had to do with a bump in the fee schedule for Medicare reimbursement.
Okay. So the next question we have here, I'm going to reference back. There's a question about slide 24. So I'm going to go back to that very quickly. So the question was, is slide 24 the kind of activity that could be stopped in those 11 states considering with current legislation?
We're looking into it, but the legislation is definitely in favor of pharmaceutical marketers because it is preventing PBMs from sending cheaper alternative messages to physicians at the point of prescribing. And the legislation basically is saying PBMs are a third party, they cannot send these messages, and if the legislation goes through, it will be definitely beneficial to pharmaceutical marketers. And actually we understand Pfizer was one of the proponents behind sponsoring this legislation.
Okay, thank you, Bill. Next question. Can you tell us more about exactly how the PBM messages come through to MDs while they are e-prescribing?
Yeah, when the physician starts to e-prescribe and when he puts the name of the drug in, the lines below it populate with the name of cheaper alternatives or generic alternatives. And that's how it happens.
Okay, next question. What was the N, in quotations, in the study of MDs responding to the surveys regarding copay coupons?
Our total N was 200, and the N for copay coupon response was somewhere in the vicinity of 20.
Okay, and the last question I have here, can you comment about e-prescribing of controlled substances, for example, CLL agents? I think that's CLL.
Yes, we understand that this is a pretty big concern, and steps are being taken to resolve it. So in short duration, we will see the permission to prescribe controlled substances through e-prescribing platforms, and that will in turn spur the growth of e-prescribing further.
And clarification, that was actually C2. Sorry about that. And one last question that just popped up. What about e-prior authorization? How widespread is this practice?
So far, it was a problem. PA was a problem. But now with Caremark itself taking the initiative and releasing a program that integrates with e-prescribing called EPA, we expect the PA process to be much more streamlined, and we understand other payers and other PBMs are also looking to release similar EPA packages, and that will in turn again facilitate this and increase total e-prescribing.
Okay, I've got another question. So Dilip and Joel, do you have an opinion about potential consolidation of e-prescribing technology providers?
Dilip, you go first.
Yes. Yeah, the conventional wisdom from what we picked up from our interviews with subject matter experts has been that there is going to be a definite consolidation in the e-prescribing technology providers, the platform providers, because there's too many of them. Some of them are not able to hack it, and the larger ones, such as Allscripts and other large ones, are going to gobble up the small ones, and it's happening already, and we expect this to continue to happen in the future.
Yep, I agree with that as well.
Okay, I've got a couple more questions that keep coming in, which is great. Next question, is there any significant delay in typical pharma launch tactics that is caused by the need to get onto e-prescribing pick lists?
There should not be a delay if the companies work with PBMs and payers and other entities ahead of schedule and get the production order so that at launch they're already in there. If this is done correctly, then there should not be a delay.
Okay. And got another one. Can you describe the Commonwealth Alliance and if it will be successful?
Yes, the Commonwealth Alliance is an alliance that was actually began. Well, the activity was spurred by McKesson and a couple other platform providers, and it is a very positive step in the right direction because it will increase interoperability and will allow physicians to see the history of all patients that they're looking to prescribe for from wherever they are. So it's definitely a positive first step, and our assessment is that we believe it will be successful. Some of the large platforms like Epic, as of last review, were not on this alliance, and therefore that was a kind of a question mark. But we feel that because of the benefit of this activity and the governmental support for interoperability, we believe this will be successful.
Okay, I've got another one here. So this is a three-part question here. Do payers drive the data in the ERX systems? So if formulary changes and the data should be correct at the point of prescribing, would payers be willing to work with pharma to facilitate this process?
Yeah, let me take a stab at that. Actually, for payers to participate in this, part of the expectation is that formularies are literally updated every month, and so it's a monthly, refresh of the data that's there. That medication histories oftentimes may be a real time or close to real time within 24 hours, if that's being requested. So I'm not sure if, based on the question, what kind of partnership in order it would need to be or potentially could be there to facilitate the process. It's actually a requirement to be engaged with and part of kind of that entire e-prescribing infrastructure nationally. The question, perhaps if just taking the next step, what about messaging? Clearly, the plans have the ability to put in for a field for a particular drug if there's prior auth that's required, if it requires step therapy, quantity limits, the kinds of things that are often included on printed formularies. I would suspect in any company in their contract and the relationship with a plan, if there's specific information about their product or positioning of that, that probably should be included in the contract or in the discussion with the plan, particularly if there's market share or if there's other rebate arrangements with that. That the expectation is similar to what we see in the old traditional way. If you're on Tier 2, it qualifies, but also if there's messaging that's included for e-prescribing, I would certainly suggest that be included as part of the conversation.
Okay, thank you, Joel. Next question. Your results indicate that MDs are willing to contain their costs by seeing pharma advertising. How strong is their preference for that? For example, would they join a fight to keep it possible for pharma manufacturers to speak to them via advertising that comes at the point of prescribing?
Well, no physician will really admit openly that they want to see advertisements on their e-prescribing platform, one after the other after the other. They'll see it if it deflates the cost of their system. Beyond that, we really don't want to speculate what they're prepared for and what they're not prepared for. That needs to be determined.
Okay. And next question. If pharma signed a contract for Tier 2, how soon will this change be made?
From what I understand, this change is made very quickly. If I remember correctly, the program is sent to the platforms every day or every week, and they update their platform information right immediately on real time. So that information is picked up by the doctor's computer pretty much quickly.
Okay, I believe, we just had another one come through. Could pharma require proof of download of this information at the MD sites?
I have to say I don't know. We just did not look into that yet.
Okay. So I believe I'm just going to give, if anyone else would like to ask a question. We did get an update, so to add on to that last question, there was the addition, could pharma require proof of download of simple MD sites regarding Tier 2 change? I don't know if that changes your answer, Bill.
Or regarding Tier 2 change. Again, it does not change my answer. We just don't know that level of detail yet.
If I can just, I can add to that if I can. Again, I don't know the specific answer to that, but I suspect that if, as a company, if you're talking to a physician or a physician group, I think one of the ways to do that is to actually, because you're curious, is how it looks on their particular system. And I don't think it would be inappropriate, particularly if there's funding involved or other type of subsidy being involved, just to validate how that information looks on their particular system. I can tell you one of the frustrations I ran into in my previous position is, even though as a plan we put that information into the spreadsheet, I'll call it the spreadsheet that actually gets loaded in to trigger a particular message. When we have followed up specifically with physicians, physician offices, or health systems, we were a bit disappointed in some cases about how that information actually was translated, or where it occurred, or if it was 3 screen hits over. by the time we got to it. So I think what my impression is there can be considerable variability, and I would encourage as a company, if you're going down the path of having a relationship or a contractual relationship or some type of subsidy, that one of the things is that you do look to see, to validate what is that going to look like. And I think, quite honestly, it is good and useful an exercise for the physician and physician groups as well, who may also be surprised at how this is displayed in their system. So think of it as a joint learning opportunity.
I actually just received another question. You mentioned that alternative products are offered as a provider types in or picks a particular product. Are all the alternatives generic, or do they also include branded products for which the PBM has contracts?
It includes branded products for which the PBM has contracts.
Agree.
Okay, looks like that is all of the questions. So I'd like to thank everyone for attending. We are going to send a follow-up to everyone who attended so that you can receive a transcript of that focus group that Philip mentioned earlier. And other than that, I'd like to just thank you once again for attending, and have a great rest of the day, and we look forward to any follow-up questions that you may have. Please don't hesitate to reach out to us. Thank you, everybody. Take care.